Very good. All good? Okay. So, too close. Like I was saying, we are just underrepresented when it comes to women actually going through fertility treatment, but we experience infertility at a higher rate than women of other ethnic groups. And so I just want to give some kind of basic information and then really just open it up for any questions that y'all have. I also like that Dr. Tasha opened by saying this may have pertained to you, but even if you are past your fertility, your childbearing years, we all know someone who is in this realm, who is having trouble getting pregnant, and so you can still use this information to be a resource for your family and for your friends. So, how many people here know that we are born with all of our eggs? Yes, that's the first thing that we have to talk about. So when we see men who are 65 and 70 and still having children, that is because men produce fresh sperm from scratch every 2 or 3 months, over and over again. And their testicles and their bodies will continue to do that until they are 50, 60, sometimes 70. So it is not unusual to see men who are older who are still fertile. We don't see women in our 50s and 60s who are pregnant. And the reason is because we are born with all the eggs we have, and we don't replenish that from the time we're born. Our egg count is actually highest before we are born. So when we're still in the uterus, halfway through a pregnancy at about 20 weeks, we have 6 or 7 million eggs in our little fetal ovaries. By the time we're born, we are down about 1 million. So it's a natural process for all females that we lose millions of eggs from our ovaries while we are still in the uterus. And then when we're born with about 1 million eggs, that still is a lot of eggs, but we don't replenish that. So from the time that we are born, our egg count is going down. It's very gradual and slow at first, but once we're in our mid-30s and older, that curve gets steeper and our egg count drops faster. And that's why we see our fertility really start to change in our 30s and 40s, because our egg number is really starting to go down. At the same time that our egg number is going down, the eggs that we are born with have been aging since we've been aging. So the age of the eggs that we still have is another factor that can affect our fertility. And again, that's why we see that as our fertility is going down, the risk of us having a miscarriage or an abnormal pregnancy, a pregnancy with a chromosome condition like Down syndrome and things like that is going up at the same time that our fertility is going down. And the chance of miscarrying or having an abnormal pregnancy going up is directly related to the age of our eggs and the chromosomes inside of our eggs. So the first thing that I want to share is that we just have to think about our age and our fertility and have a plan for that. And I always tell women, plan for your fertility and your family the same way that you plan for your career and your job and your relationship. We have to have a plan. You have to think about it and be intentional and be mindful about that. I see many women who spend years going through college and education and career, and then they think about, now that I've got everything set, now I'm ready to have a family. And sometimes they're in their 40s or they're older and they may be challenged because they put it off and focused on other things. About 1 in 8 couples have trouble getting pregnant. And so when we say, how do you define infertility, it's really based on a woman's age, again, because of how our egg number changes over time. So in general, we say you have infertility if you are under 35 years old and you've been having regular, unprotected intercourse for 12 months straight. If you haven't gotten pregnant, that meets the definition of infertility. But once we're over 35, we shorten that to 6 months. If we're over 40, we bring it down to 3 months. So based on how old you are when you start trying also determines when you should seek care, see a fertility specialist, or at least initiate the conversation with your OBGYN. And if you have other factors, you don't have to wait out 12, 6, 3 months. If you know that you've got blocked tubes from a prior infection, or you had a tubal ligation, or you have PCOS and you have 1 period a year, you don't ovulate, or you have endometriosis, if you know that your partner has a low sperm count, things like that, if he's had a vasectomy, then you go right to the fertility specialist. You don't wait out the timing based on your age. But if I see a couple, if I see a male and a female couple come into my office who's been having trouble getting pregnant, we always go back to the basics. What is the egg function, the egg count? What's the sperm count and sperm function? And what's the anatomy of the woman? Does she have a uterus full of fibroids? Does she have blocked tubes that may be preventing a pregnancy? So we always cover that. And if I see a couple, we evaluate the male partner at the same time as the female. It's a common myth that infertility is a female issue. And I've seen many women who had a male partner, and the male said, I know it's not me, I'm fine, I have a child before, and the woman has gone through years of testing and what could be the problem and what's going on, only to eventually get to the male evaluation and find out that there was a sperm factor all along. So when we see couples, male and female factors are equal. About 40% of couples, there's a female factor. About 40% of couples, there's a male factor. And then there's a fraction where it could be both. So we have to evaluate both from the beginning. I also take care of single women. I take care of women in same-sex relationships. We still have to at least consider for a woman the anatomy and the egg function or the egg reserve before we just jump to treatment. Sometimes patients will say, well, I'm single, or my wife and I are together, so we just need sperm to get pregnant. And then we find fibroids and inflamed tubes and endometriosis and things like that. So we still have to start with the basics of egg function, anatomy, and sperm analysis if there's a male partner. So we have some simple testing that we can do to assess what we call our ovarian reserve. So there's 2 hormone tests that we order, and these can be ordered by your OBGYN. You don't have to go all the way to a fertility specialist for the testing. But the 2 hormones are AMH, which stands for anti-mullerian hormone, and FSH, stands for follicle stimulating hormone. The reason that our egg count goes down is because you don't lose 1 egg a month when you have a cycle. So every month when your period begins, there are usually 50 or more microscopic eggs that start to grow in the ovaries. And some of those eggs will continue to grow into what's called a follicle. A follicle is a little egg sac in the ovary, and there's an egg inside each one. So you have 50 to 100 microscopic eggs. Some grow as follicles, and then 1 follicle develops all the way. That's the egg that fully forms and ovulates that cycle. Once your main follicle is determined, all those 50 plus eggs that started to grow that cycle just die off. You lose all those eggs. Then you ovulate your 1 egg. If that ovulated egg gets fertilized, then you're pregnant. If the ovulated egg does not get fertilized, then you'll have a period about 2 weeks after you ovulate if you're having regular cycles. And with your next period, you start over with a brand new 50 to 100 eggs. Some become follicles, 1 goes all the way. That's a monthly process for each of us, and there's nothing that changes that. So whether you're in puberty, pregnant, on birth control, breastfeeding, whatever we're doing, behind the scenes, every month, there's a whole wave of eggs that start and just die off. And that's what adds up over time. So those waves of eggs are producing AMH. So if we draw your blood any day in your cycle and just check your AMH level, that's like a snapshot of how active your ovaries are. A normal AMH level is between 1 to 4. And naturally, as our ovaries slow down, they produce less AMH. And when your AMH level is less than 1, then that's a sign of lower egg reserve. And how far below 1 tells us to what degree. The other hormone, FSH, is follicle stimulating hormone, and that's produced by the pituitary gland in the brain. And it's the brain telling that 1 follicle to grow up and ovulate. In order for FSH to be reliable, we have to check that around the 3rd day of your cycle. So day 1 is the first day that your period starts, full flow bleeding. And then around the 3rd day, if we draw the blood and check a FSH level, a normal level is going to be less than 10. Naturally, as the ovary slows down, it needs more stimulation for it to kick in and function, so the FSH gets higher over time. So a high FSH is a sign of decreasing egg reserve also. So we check those levels, and then we can also do an ultrasound to just look at the ovaries and count how many of those little follicles we see. They're like teeny little dots in the ovary. And we want to see at least 4 to 5 in each ovary to say the ovaries are active and producing follicles, and one of these is going to develop and ovulate. So that's how we check an egg reserve, with those 3 factors: ultrasound, AMH, FSH, and then we also look at a woman's age. Our age, once we get into our late 30s and over 40, is a bigger predictor of our fertility than even those hormone levels. And so what we know first is that average fertility for a young, healthy, fertile couple that gets pregnant naturally that I never see, the chance of getting pregnant is about 20 to 25% per month, which sounds very low. But it's really about 1 in 5 chance of everything. There's so many things that need to happen for each of us to be here. You have to ovulate a healthy egg. It needs to get picked up by the end of the fallopian tube. You have to have intercourse at the right time. Healthy sperm from the vagina have to go all the way through the uterus, down the tube, find the egg. Egg gets fertilized, needs to develop normally, and then the embryo has to go through the tube, back into the uterus, find a healthy place to implant, and then develop there normally. About 1 in 5 chance of all that happening. So there's many ovulations that don't result in a pregnancy. And so when we think about a woman's age, so average fertility is about 20 to 25% per month. By the time we are 40, based on our age and the age of our eggs, our chance of natural pregnancy is about 10 to 15%. By the time we're 45, it's about 5% or less. And like I mentioned, the risk of abnormal pregnancy and miscarriage is going up at the same time. And so the average risk of an early miscarriage in a younger lady is about 15 to 20% per pregnancy. By the time we're 40 years old, it's about 50% chance of an early miscarriage or abnormal pregnancy every time we get pregnant. And by the time we're 45 or older, over 90% of our pregnancies do not develop normally because of the age of our eggs. So again, we have to think about it, be proactive, and the age matters. So even if normal AMH and FSH, if we're over 40, our age starts to be a bigger factor than even having normal hormone levels. So that's the egg factor. I mentioned anatomic factors, so we have to do, with the ultrasound, look at the ovaries. We also look at the uterus, see if it's normal shape and size. Are there fibroids that are there? We know that fibroids, if they're large enough or if they're in the middle of the uterus where embryo needs to implant, that they can affect our fertility. Fibroids can affect our pregnancy outcomes. They can also increase our risk of early miscarriage, preterm delivery, more bleeding and heavy blood loss at a delivery and things like that. We do an X-ray test called an HSG, which stands for hysterosalpingogram, or it's called a dye test. We basically flush fluid or dye through the uterus and fallopian tubes while we lay under an X-ray machine. We can capture pictures as the dye flows through. And if the dye goes into the tube and spills out the end, that confirms that the tubes are open, so that when the egg is ovulated, sperm and egg have an open path to connect. Some common reasons for tubes to be blocked are, again, if a woman's had a tubal ligation, if she's had pelvic surgery on the tubes, appendicitis, things like that, that can cause inflammation in the pelvis. A pelvic infection like gonorrhea, chlamydia can cause inflammation in the pelvis and around the tubes. Endometriosis can also cause inflammation and scar tissue around the tubes. So we have to make sure the tubes are open. And then if there's a male partner, a semen analysis is a basic test for a man where we can ask him to collect a semen sample in a specimen cup, and we just take that to a microscope in our laboratory, and we can look and count up how many active, healthy sperm are present in the sample. So that's the basics that we do. When I see a couple who's having trouble getting pregnant, or I see a woman who wants a fertility assessment, we always cover those bases. And then we can make a treatment plan from there. I'm going to open it up for questions, but we can talk about egg freezing, in vitro, insemination, what's the process look like. We offer all of those treatments, and it's very individualized depending on what a patient is coming in for. Surrogacy, we do all of those things. So I'll pause there and see if y'all have any questions, and then I can answer any of that or talk some more. Yes, in the back.
I have a question about two things, two-part question. One is, I've heard about I think it's CoQ10. Is that like a CoQ10? Yeah, like pills that you can possibly take to assist with helping your fertilization, one. And then, like, what is your thoughts about that? And then two, the cost. Like, do most insurance companies cover it, or is there like a payment plan? Like, how we working on that?
Thank you. Excellent question. So first, for the CoQ10, CoQ10 is an antioxidant. It's a supplement. The formal name for it is ubiquinol, but you can see it as CoQ10, and you can get that from GNC, Vitamin Shop, Publix Pharmacy, and different places. And it's an antioxidant. So as we're exposed to toxins in the environment and in our diet, they can produce free radicals in our system. And these are oxygen molecules that can attack and damage our cells and cause oxidative stress on the cells, and then the cells don't function as well. So CoQ10 is an antioxidant that can help to reduce the free radical damage of the cells throughout our body, including on the ovary. And so we do recommend CoQ10 just as a supplement to help with the health of the follicles that are there. We don't have any treatments that can reverse the aging process or slow down the number of eggs that are drifting or things like that, but we do recommend CoQ10 just as a supplement for health to reduce oxidative stress throughout the body, including the cells of the ovary. You get it over the counter, and we recommend taking 200 to 300 milligrams twice a day. As far as cost for fertility treatments, that's another concern for a lot of people, and sometimes keeps people away, and they feel like the only fertility treatment that I can do is in vitro, and it's going to cost $1 million, and I can't afford it, so I'm not even going to go talk to anybody. We're seeing more patients who have insurance coverage for treatment. About 60% of the patients that I see have coverage, and it's very individualized. So sometimes patients will say, well, can you tell me the company that's going to cover insurance? It's really based on your employer and what they contract through. There are newer fertility-based insurance companies. There's one called Progeny, there's one called Carrot that only cover fertility care. But I always just recommend when you have open enrollment, look at the different plans and ask specifically, do you cover fertility treatment? Do you cover the medications? Do you cover egg freezing? Do you cover in vitro? Because it's different, and some may cover some treatments, but not all. So you have to be specific about that. Yes, ma'am. And then I'll just say in general, the cost of fertility treatment, if you don't have insurance coverage, insemination is like the first level of treatment that we do. That's $2,000 to do a cycle. We call it IUI, for intrauterine insemination. And then you take medicines with that for about $200. That's for 1 month of treatment. You might do that for a couple months. If you do in vitro, one cycle starts at $13,000, and that is a significant cost. The medicines for IVF are usually $7,000 or $8,000. So fertility medicines are high. If you freeze your eggs, those treatments start around $8,000 for one cycle, and then you still have to pay the medication, pay for the medications, which is another $7,000. So if you freeze your eggs, it's usually going to be close to $15,000 to do that. If you do those type of treatments, you also have to factor in that once you get your eggs or your embryos frozen, you have to pay to keep them stored. So you will pay a storage fee, which is going to be usually like $900 to $1,000 a year of storage. And you may be storing these for years and years before you come back to use them. So you got to think about all that too. Yes, ma'am, in the front.
I have two questions actually. So my grandmother would always say that when she was growing up, she started having children very early, 14, right? 13 children. And the last 4 children were born when the doctor told her to take Geritol as birth control, only to find out Geritol makes you fertile. And I have not seen that in the store anymore. Is that true, number one? But number two, when you start talking about fertility and freezing eggs, in this climate of Roe versus Wade, what does that mean? I've frozen my eggs. What does the government say that I now can do with these eggs, because it's recognizing them in some places as people, right? And so that would be my question. Here in the South in Georgia.
Yes, thank you. First question was about Geritol. So I still see patients who are taking Geritol. So I think that it's available somewhere. You can get it. It's basically a vitamin supplement with iron in it. I think it's anecdotal and maybe kind of passed down that Geritol can help you with your fertility. It's not harmful to you. I don't know that it's going to boost it. It's definitely not going to be prevent a pregnancy, but I do see women still take Geritol. We get a lot of questions. Since the election on Tuesday, we have had panicked people who are just like, I don't know if I want to do treatment anymore because I'm scared, or what's going to happen to my eggs or my embryos that are here. At this point, there is nothing different about what we're doing in Georgia. They did have a ruling in Alabama, which was very disruptive, where there was a case that some embryos were lost. And the couple sued the clinic, and the outcome of the case was that they determined that those embryos had personhood and they were people. And so it does kind of back up the line. So in Alabama, because embryos have personhood, they can't discard embryos in Alabama, even if they're abnormal. So there are couples there who are required to keep their embryos stored because they can. And we can do testing of an embryo. We can go through and see, is this going to be a chromosomally normal embryo, lead to a healthy pregnancy? If we have determined it's not going to be viable, then couples may request to discard those embryos. Say, I'm never going to put these in my body. I don't want to pay to store them forever. Can we discard these? And in Georgia, you can do that. In Alabama, they cannot. And because of the legal climate and everybody's nervous, other states do not necessarily want you to bring your embryos over here for discard. They're like, we don't want to be involved in that either. So it's a messy situation in Alabama. But nothing has changed as far as how we are practicing in Georgia. An egg is an egg, it's not fertilized. We can freeze eggs, we can discard eggs and thaw them out if a patient does not choose to use them. We can discard embryos, we can form embryos. And what was unfortunate about that ruling is that kind of the backlash from that is that, you know, politicians say that we should create one embryo at a time so that you don't have extra embryos to discard. Human or just reproduction in general is very inefficient. So one embryo one egg fertilized, become an embryo and a baby is highly unlikely. So when we do fertility treatments, we stimulate the ovaries to produce multiple eggs because there is an attrition from how many eggs you start with to how many fertilize and become a healthy embryo and a baby. And so if down the line, couples are forced to create one embryo at a time, that's going to be a very time-consuming, cumbersome, and expensive process, and it's going to be inefficient compared to if we can get several eggs and get to the healthy embryo and help couples faster. But again, right now, there's no change in anything that we do. The main ruling in Georgia is with the heartbeat. And so pregnancy cannot be terminated in Georgia once it is viable and there's a detectable heartbeat, which is detectable by about 6 weeks. So even if it's an abnormal pregnancy, if it's not life-threatening for the woman to carry that pregnancy, then she cannot terminate in Georgia. And that's the rule that has been in place and hasn't changed up to date. But difficult. Was there someone in the back that had a question earlier?
Any questions in the back?
Yes.
Yes, ma'am.
I'm sorry if I missed it, but can you talk more about how infertility has to do with the different surgical options that we have that has to do with fibroids? So I know we have multiple options that we can do when it comes to surgical, but what does it mean if I am like, hey, I'm young, I still want kids, but I'm going through this medical issue?
Yes. And so I think the previous talk, we talked about all the different options for fibroids. You can have a myomectomy, you can have a hysterectomy, you can have a uterine artery embolization. There are targeted procedures now, ACESA, in places where you can just do focused ablation of a fibroid to keep the uterus intact. For most fertility specialists, we're still recommending a myomectomy at this point because we have the most evidence about that. So the first thing to think about is, you know, where are your fibroids and do they impact your fertility? So if you have an ultrasound and we do what's called a saline ultrasound, we can put fluid inside the uterus, kind of open up the cavity. It's the size and location of fibroids that matters. So even if a fibroid is the size of a blueberry, if it's right in the middle of the uterine cavity where a microscopic embryo needs to implant, then we'll usually recommend that that be removed. If there are fibroids that are not in the cavity and kind of in the wall around the cavity and they're not too big, then we usually say you can just monitor those, and those are not going to impact fertility. Even if the fibroid's not in the cavity, if it's big enough, it can be an issue. So once fibroids are bigger than 5 or 6 centimeters, even if they're not distorting the cavity, we have good evidence that they can affect implantation of an embryo. They can increase the risk of miscarriage. They can grow during a pregnancy and lead to an early delivery that might be before the pregnancy is viable, where you can have a premature baby. They often require you having a C-section if they're in a bad location, and things like that. So the first step is to say, do these fibroids look like they're in a size or location that would impact my fertility? If the fibroids are completely within the cavity, then outpatient surgery called a hysteroscopy can usually address that. It requires no cuts on the belly. You can just go through the cervix, like a pap smear procedure under anesthesia, shave fibroids out from the inside, and then the inside of the uterus is smooth and clear for implantation. If fibroids are larger, you would still need to go through the abdomen, either with a robot or a larger incision to remove those. Uterine artery embolization is a good procedure for the right candidate, but fertility doctors don't really like patients to have that. When you have they call it UFE, which is uterine fibroid embolization, but it's actually a uterine artery embolization. You're not just embolizing or starving the fibroid. You're putting pellets in the major arteries, the uterine arteries that go to the uterus. There's collateral blood vessels that are still going to keep the uterus viable and alive, so you're not going to the tissue's going to die, but you take a good amount of blood flow away from the whole uterus when you block the uterine arteries. And so fibroids usually do shrink when you do that, but you can also affect the rest of the uterus that receives blood flow from the uterine arteries. And so there are definitely women who have a uterine artery embolization and who have a normal pregnancy and they do fine, but it is a higher risk to have infertility after that, or to have problems with how the embryo implants, or how the lining of the uterus develop for implantation and things like that. And so I see the subset of patients who've had a UAE and are having trouble. And sometimes it's hard to overcome those effects. We can't reperfuse the uterus after you've taken that blood flow away, and if the uterine lining is not functioning well, then sometimes that can be an infertility factor. So we say UFE or UAE is not recommended for women who want to carry a pregnancy later. But for women who are not candidates for surgery, can't go under anesthesia, want an outpatient procedure, and they are not planning to be pregnant, then the UAE can be a good option for them.
Thank you.
You're welcome. Yes, ma'am.
Earlier you mentioned cycles, right, treatment cycles, and I know there's a cost to storage and all these things, so what's the average cycle, that it would take average for a couple to get pregnant?
So it depends on what type of treatment you do. So we do the basics first. Are my tubes open? Is my uterus clear? My ovaries active? Does my partner have sperm? If a woman is single or she is using donor sperm, then we just do her evaluation. If the tubes are open, then a lot of women will begin with insemination. So the first treatment that we can offer is IUI, which stands for intrauterine insemination. If you do an IUI cycle, we're basically kind of boosting the natural process. Everything still happens in the body. So some women may do a natural IUI cycle if they don't have a male partner and they're just doing donor sperm. Well, we can track her ovulation. So she tells us when her period starts. Ovulation is usually going to happen around day 14 of a 28-day cycle. So just to step back for a minute, regular cycle length is about 28 to 30 days. So day 1 is the day that you start a period. There's a microscopic egg starting to form at that point, and that follicle is going to grow into an egg ready to ovulate, usually by day 14. Then you're going to ovulate. You release the egg. Once the egg is released, there's a little crater in the ovary that's left behind when the egg's released called the corpus luteum that makes progesterone. So you're going to have progesterone starting to go up in the second half of your cycle. Your corpus luteum is slowly shriveling up from the time that you ovulate, and the corpus luteum lives about 14 days. So if you ovulate on day 14, then your corpus luteum is going to shrivel up and it's going to stop making progesterone 14 days later. And when it shrivels up, stops making progesterone, that drop in progesterone makes you bleed. So that's how you get to a 28-day cycle. So if we're doing an IUI, we're just overlapping that. A woman has period on day 1, we're going to track her ovulation either naturally, or we can get fertility pills like Clomid or Letrozole, which are pills that a woman takes for 5 days around the 3rd or 4th day of the cycle to stimulate a follicle to grow. We can see when she's going to ovulate. And then to inseminate means that we take sperm, fresh sperm from a partner, frozen sperm from a donor. We load it up in a catheter, pass that through the cervix, and push a little syringe and just place the sperm in the top of the uterus. It's like a pap smear. It takes 5 minutes, no anesthesia. And we just place the sperm there. And then the sperm are going to travel down the tubes that we've confirmed are open, find the egg that's been ovulated. And then you wait 2 weeks after an insemination. Around day 28, if that egg's got fertilized, you have a positive pregnancy test. So that's one cycle. The chance of pregnancy when we do fertility treatment like IUI, we're trying to approach natural fertility. So like I mentioned, average fertility for a fertile couple is 20 to 25% per month. So for one IUI cycle, we wait 2 weeks after insemination, our chance of pregnancy is about 15 to 20%. So we definitely see patients who get pregnant on the first IUI, but many couples do more than one IUI cycle before they get pregnant, or many women. So you inseminate, wait 2 weeks. If your pregnancy test is positive, we confirm the pregnancy, and then you see your OB/GYN for your prenatal care. If 2 weeks after insemination, your period starts and your pregnancy test is negative, we say it's 1 in 5. Let's do it again. You can start over and do another cycle. So you start over with the medications and the cost, and you may go through that. We usually recommend 2 or 3 cycles of IUI before you say, I haven't gotten pregnant with this, I'm gonna move on to the next level. The next level of treatment is in vitro, IVF, or in vitro fertilization. And with IVF, we bypass that fertilization process in the body altogether. And we can take eggs from the woman's ovary and fertilize in the laboratory, and then take the embryo and put it back. Reasons to go directly to in vitro would be if both the tubes are blocked on the HSG, so the sperm and egg cannot connect in the body, or if a male partner has a low sperm count and we feel like there's not enough sperm that should be able to travel all the way to the egg. That's another reason to do IVF. If you freeze your eggs, you are doing the first half of in vitro. It's exactly the same process. And with either of those, our goal is to get many eggs to grow. Like I mentioned, there's a wave of eggs that start, one's gonna ovulate, the rest of them fall back. If we do in vitro or freeze eggs, we're gonna give a woman hormones to target that wave and keep more of those eggs growing than just the natural one. So none of our fertility treatments change our egg function. They don't increase our egg count. They don't cut it down faster. It's just that instead of that wave start and die off, we're gonna catch more of those eggs and keep them growing. The medicines to stimulate that wave for in vitro or egg freezing are shots. So when women do in vitro, they give themselves hormone shots at home every evening for close to 2 weeks to stimulate those follicles to keep growing instead of falling back. It's a fine needle like an insulin syringe injected under the skin of the belly or the front part of the thigh. But women do these at home every evening for close to 2 weeks. And during that 2 weeks, they're coming into the office and having a vaginal ultrasound every other day, 7 days a week, to look at the ovaries. And at first, follicles are tiny little dots in the ovary, but as the eggs grow, they're growing into cysts in the ovary. So they come in and we measure those cysts in the ovary every couple of days. And we draw blood every time she comes in and check estrogen and hormone levels, which go up as those eggs are growing. The normal size of our ovary is like a cherry tomato, it's like 2 or 3 centimeters. If many follicles or eggs develop, each ovary will usually be the size of an orange or sometimes a grapefruit after taking those shots for 2 weeks. So women can feel kind of bloated and heavy and full because their ovaries are swelling in their pelvis. And so we're just tracking along, and when we see several follicles that are big enough, then we expect that those microscopic eggs in the follicles are developed enough to collect. Can't see the eggs, but based on the size of the follicle, the hormone levels, we say, let's get the eggs. To collect eggs from the ovary, we have to put women under anesthesia. And so once they're asleep, we do another vaginal ultrasound, and we have a long needle that we pass straight through the vagina into the pelvis and the ovary, and we're looking on the ultrasound screen, and we pass the needle into one follicle and we drain it through the needle. You suck the fluid out of the follicle and the microscopic egg comes out. And then we back the needle up and go into the next. So we're watching ourselves on the ultrasound screen just drain follicles one at a time. And the fluid coming out of the ovary is going into test tubes that we're passing to our embryologist who's next door to a microscope. And they're looking through the fluid and they're identifying microscopic eggs in the fluid. And as we're doing a procedure, we can hear them counting. They're saying, I got 1, 2, 3, 4, 7, 8, 9, 10 eggs. So we know that we're getting eggs from the ovaries. We do that for both ovaries. That takes about 30 minutes to do. And then we take those eggs into the lab and look under the microscope and say which of these eggs are fully formed or mature enough to fertilize or save for later. If an egg is very immature, it won't fertilize, so we discard those. Now, if a woman was freezing her eggs, we would stop right there. We'd say, we got this many mature eggs, we're gonna freeze them, and if you come back in the future, then we'll work it out with your eggs. If a woman's doing in vitro, we collect her eggs and we have sperm right there from her partner or donor, and we take the sperm and eggs and combine them the same day that those eggs were collected. We place them in an incubator in our laboratory, and we can monitor as those eggs fertilize and grow into embryos. From the day that a sperm and egg are combined, an embryo forms 5 or 6 days later. And so we can see that under the microscope. And once we have a fully formed embryo, we can pick that microscopic embryo up in a little catheter, pass it through the cervix, and just place it gently right inside the uterus where it needs to implant. And then we do a pregnancy test 10 days later, and we know if we're pregnant from that embryo transfer already. So if a woman freezes her eggs, we always talk about if you freeze your eggs now, you have to be prepared to come back and do the second half later. You can't thaw an egg and put it back in the body and let things happen there. We have to finish in vitro and then take the embryo and put that back. We can freeze eggs and embryos forever. They do not expire or go bad or change. And you could freeze them and come back next month. I've seen couples thaw an embryo 10 and 15 years later and have a baby from that frozen embryo. So we can literally freeze them and you can come back when you're ready. Another thing that we can do with embryos is we can test them in the laboratory. So like I mentioned, for our age, the health of the pregnancy of the embryo is tied to our age. So women do in vitro and they say, I'm high risk that every embryo may not be a healthy one. I want to test my embryos first. We can do that. It's called PGT, which stands for pre-implantation genetic testing. And with PGT, we can take the formed embryo and biopsy the embryo and just remove a few cells from the embryo, send it to a special laboratory, and they can run a full chromosome count on the embryo. They can tell the sex of the embryo. They can make sure there's no Down syndrome or chromosome conditions or things like that. Sometimes we also take care of couples who carry a genetic condition. Like I have several couples who have sickle cell trait. If the man and the woman both have sickle cell trait, then there's a 1 in 4 chance they'll both pass it at the same time and the baby will have sickle cell disease. So if we have couples who are carriers of the same trait, we can take their embryos and test them first and say, is this the embryo affected with sickle cell? And if it is, that's not the one we're going to select. We're going to select one that would not be born with that. So that's another reason that couples do in vitro. So we go straight to IVF if there's block 2, the sperm factor, if couples want to do genetic testing, and you do the first half if you want to freeze your eggs for the future. And eggs can be frozen for social reasons. If I'm single, I'm not ready to be pregnant, but I want to catch my eggs while I'm younger. Sometimes we get referrals from women who were diagnosed with breast cancer very recently, and they want to freeze their eggs before they go through chemotherapy and things that may affect their egg reserve. So that's another reason why some women may want to freeze their eggs, so we can do that also. Yes?
I would like to know if a relative or friend can receive your embryo or eggs that you have frozen or stored.
Yes, yes. And so when women use an egg donor, we also have egg donors. So if we get to a point where our egg reserve or our age is limiting our fertility, then some women may get eggs from a younger woman. We have anonymous egg donors, and then we have what we call known egg donors. We recruit young ladies just on a rolling basis throughout the country to donate their eggs. And for anonymous egg donors, we are selecting women because they're young, they're healthy, they have normal AMH and FSH, and we expect their egg quality to be good. For those donors, they're 21 to 31 years old. And we do screening for the donors. They have to meet with a psychologist to pass the screening, test their egg supply. We do genetic testing for donors. And if they pass that screening, then they do the same process I just mentioned. They go through and take shots for 2 weeks, go into anesthesia, we collect their eggs, and then we can store those eggs for other couples. It's really based on the age of the eggs. So if I have a patient who's 45 and she says, what's going to give me the highest chance of pregnancy? We're going to say it's going to be an egg donor. If we get eggs from a donor who's under 30, the chance of pregnancy for that 45-year-old woman is going to be based on the age of the donor. So at 45, my chance of pregnancy with my eggs is less than 5%. If I take the eggs from this lady under 30 and carry that pregnancy from her egg, my chance of pregnancy is 50 to 60%. And it's based on her age, not the age that I am when I'm carrying. We also have some women who have a known egg donor. So if women have a younger relative or friend, then yes, we screen them to make sure. And sometimes women will say, well, my sister volunteered to donate eggs. But if your sister is your age or older, then she's probably not the best candidate to donate. So we still have to screen and say, we want to make sure that this is going to be the best option for you. But yes, we do have that. When we do what's called third-party treatment like that, one of the first things we have to do is think about the psychological impact of carrying a pregnancy from someone else's egg, whether it's anonymous or someone that you know. So we always begin, it's required that couples meet with a trained third-party psychologist trained in infertility to talk to them about that. So if they're having an anonymous egg donor, then the woman, if she has a partner, they talk to the counselor. How do we really feel? Are we okay with carrying a pregnancy from someone else's egg? If you know your donor, the recipient of the egg meets that counselor. The donor, if she has a partner, they work with that same counselor and talk about how do I feel about donating my eggs to her. We're gonna see you at family reunion, are we all okay? And then there's a third visit where the counselor brings all of them together and they have a group session to really talk through, are we all comfortable with this arrangement? Also, if you know your donor, then we refer couples to a reproductive attorney for legal agreements and contracts when you do that. The same thing if we have a surrogate, which we call a gestational carrier. So if a woman is unable to carry the pregnancy, then she can work through an agency and be matched with a woman who can carry for her. Or if she has a relative or a friend who volunteers to carry for her, then we can do that also, get the embryos, and we can transfer the embryo to the gestational carrier. Again, we start with third-party counseling for everybody involved and legal counseling and contracts and agreements when you have a gestational carrier or surrogacy arrangement. And that's for the benefit of everybody involved. Yes?
I just have one more question.
That's good.
It seems like, maybe it's a comment, maybe it's a time, it seems like this is a time I'm hearing more about infertility than I ever heard before. Like I don't remember, and again, we don't talk about things. Like as women, we just don't talk about things. But I don't recall like my aunts, my mom, my grandmothers, my great aunt, like any of them having conversations about infertility. Has it always been this sad, this sad state of affairs, or has it been because of the type of lifestyle choices and differences that we've made, it has now risen to the forefront because now it's affecting more broadly
Yes.
people?
It's a combination. So, I think that we all grew up knowing people in our neighborhood, in our circle, our family who just didn't have children, and we didn't talk about it. They just never did. And so they probably had infertility that was not recognized, diagnosed, or treated. We are seeing more women who are seeking fertility care now. Awareness is increasing. We're talking about it more. There was so much, especially in our community, of the stigma and the shame and the stereotype that we It's placed on all of us that Black women, we're super women, we're super fertile. We don't ask for help. We don't talk about our struggles. And so if we're trying at home and it's not working, we're just not even always comfortable to say anything. I must be the only person in this room who's having trouble, and you're not. But we don't share. We're getting better about sharing our stories and our experiences, and it's becoming more acceptable for us to seek fertility care. Now, there are things that we see that are increasing the number of women freezing eggs and coming to the fertility specialist, especially for us. So age is one of those factors. Again, we are more likely, when we look at statistics of women going through fertility treatment, Black women, we are more likely to be older when we get to fertility treatment. We've waited longer before we even see the fertility provider because we're more likely to say we just need to keep trying. And sometimes providers tell us, y'all are fertile, so you just keep on trying and you'll get pregnant. And so we spend years, just kind of going through before we even get to the doctor to have our evaluation. And depending on how long we waited, if we're in our 40s when we get there, now that's another factor against us. If we've prioritized career and things, then that also is increasing the number of women we see who are now coming in to freeze their eggs or having trouble because they postponed and they waited longer. Our lifestyle is definitely a factor, and Dr. Tosh already touched on this. But another factor when we see women going for fertility care is that Black women have higher BMI when we show up for fertility treatment. And that is directly tied to just our diet and how much or how little we exercise, the quality of our food, the type of food that we eat. And so we know that even if you do in vitro, the Cadillac fertility treatment, if your BMI is higher, you have fibroids, if we're Black, our outcomes are lower. When we're less likely to do fertility treatment and then we get there, our pregnancy rates are lower across the board compared to women of other ethnic groups. And so we have to focus on what can we do to put ourselves in a better position when we get there, manage our fibroids, keep a healthy weight, lose weight if we're overweight, focus on what we're eating to take care of ourselves. So I think there are some environmental factors and lifestyle that are, kind of bringing this to the forefront, but awareness also, thankfully, is bringing more women in.
So when do you start having, infertility conversations with nieces, with sisters? Like, when do you start
Now.
talking about that?
The first thing, it doesn't have to be scary, like, oh, you got to go freeze your eggs, because a lot of times I see women who say all through high school and college, all I was told was don't get pregnant, get your degree first, get your job, and prevent. And then they're like, I did all that, and now that I've got my partner and I'm settled and I'm trying, I'm having trouble. And, all this time I was told the opposite. So it's never too young to talk to a young woman about just her reproductive health in general. And just, this is what a cycle is. This is what happens every cycle when eggs start to form and eggs fall back and egg count is drifting down. When we talk about just freezing eggs or fertility preservation, the best age to do that is as young as possible, like mid-30s or younger. And so it's never too early to talk about it. And we want OBGYNs to also, to start the conversation. Dr. Tosh is great about that. When you're having your annual exam, it takes 2 seconds to say, are you thinking about having a baby? You thinking about freezing your eggs? And if they say, nope, I'm done, then move on. But if they say, I'm kind of curious, is there a test I can do to check my egg supply? Yes, let's draw AMH level. We can do that today. Doesn't matter where you are in your cycle. And so it's just having those conversations early and just increasing the awareness and the comfortability of that conversation that I think is important. Everybody's not going to freeze their eggs or come to my office for fertility treatment, but just knowing. I see way too many women when I give these kind of statistics and they're 40 plus and they say, I wish that someone had told me these things before. This is the first time I'm ever hearing all of this. And so we just have to talk to our young ladies and just give them the information, not just about egg supply and things like that, but how to be healthy and how to protect your reproductive health and prevent STDs and things that can inflame your tubes and limit your fertility later. And so we have to start that now.
Anybody else have any questions?
Yes.
So,
So just the people that don't have regular cycles, what is the regulate us to prepare for the fertility treatment?
So the most common reason for a young lady to have irregular cycles is PCOS, or polycystic ovary syndrome. And talking like boom, 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 we see that all the time. And so PCOS, there are 3 features of PCOS, and to meet the textbook definition, you need 2 of those 3. So polycystic ovary means that when you look at the ovaries on an ultrasound, there are multiple cysts, those little follicles, not big cysts, but just tons of follicles. And they're usually lined up around the edge of the ovary. So on an ultrasound, we say it looks like a string of pearls or string of beads around the ovary. So ovaries that look polycystic. For many women, even though they have more follicles than normal, the follicles don't always develop and ovulate on time. In order for you to have a regular cycle, like I mentioned, you have to ovulate, you gotta have a corpus luteum shrinks, and then you have a period. If your follicle never ovulates, then you don't get that second half and signal for your period to start. So you can have a lot of follicles in the ovary, but if they stall out and never ovulate, then you're not gonna have a period. So either you can ovulate later, and instead of coming at 28 days, if you don't ovulate till day 20 something, that means your cycle's gonna come 14 days after that. So 34, 45 day cycles, or no cycle for months. And then the third feature is that polycystic ovaries can produce more testosterone. So many women with PCOS have acne, oily skin, hair on your chin, chest around your breast, and things like that. And so again, you need 2 of the 3. Ovaries that look polycystic, signs of high testosterone, and irregular cycles to meet the definition. But I also see women who say, I don't look like the textbook that has every single feature, so I must not have PCOS, or I've been to several OBGYNs, nobody's ever diagnosed me with PCOS because I didn't meet all the criteria. But you don't have to fit that to have PCOS. There's a range. You can have all the features for sure, but I see women in the middle. I see women who have minimal to no symptoms until we look at their ultrasound, or we check their AMH is very high, or things like that. And so there can be a range of how the PCOS presents itself. If it's irregular cycles as your main feature of PCOS, if you're not trying to get pregnant, birth control pills is usually what's prescribed to regulate cycles. It's very common for me to hear a woman say, my periods were irregular, I took birth control pills until I finished college, and when I stopped taking the pill, my cycle was irregular on the pills. When I stopped taking the pills, my cycle became irregular. Your cycle was always irregular. The pills just masked that and gave you a regular cycle, but once you stop taking it, your ovary is going to go back to the function that it already had. So you can take pills to regulate the cycle, which is important because if a woman goes too long without having a period, the lining of the uterus can just stack up and gets thicker and thicker, and it can turn into abnormal or precancerous tissue. And there's a higher risk of developing uterine cancer if you never shed your uterine lining. So pills is a way to give you a regular cycle, shed your lining, protect your uterus. Some women, if they don't want to take birth control pills every day, can take progesterone like Provera. Take a pill for 10 days, and that will break your lining down as progesterone, and that can give you a cycle. If women have PCOS or have irregular cycles and they're ready to be pregnant, then that's where the fertility pills like Clomid or Letrozole are usually helpful. Pills that can be taken at the start of a cycle, even if we have to induce the period with progesterone. And those pills can target those tiny follicles, and we're trying to stimulate one of those follicles to grow up and ovulate with the pills. If women's ovaries do not respond to the pills, then we can use the injections to stimulate, but those injections can stimulate too many follicles to develop. And so if you're taking the injections, we usually are saving those for an in vitro cycle. Sometimes if the cycles are irregular, it might also be a sign that the ovarian function is decreasing, especially in older women. So we don't want to assume my cycles are irregular, you must have PCO. You still have to have the evaluation. How many follicles do we see on the ultrasound? What's your AMH, FSH? And that helps us to make recommendations for treatment, how to help you regulate your cycles or help you get pregnant if you're ready to do that. Yes, ma'am.
Hi. Recently, my daughter just found out that she had an abnormal uterus, and so my question is, would it be still tries to, get pregnant without sterilization like that? Or secondly, is there treatment? And third, how, the abnormal uterus, was it any way to know that she had abnormal uterus before this?
So it depends on what the abnormality is. And so when we're forming bicornuate, okay. So when we're forming as a fetus in the uterus actually starts off as two parallel channels. And the two channels are developing, there's a tube and an ovary that develops on each side. And these two channels develop like these microphones like this. Two channels that are side by side. And then the channels fuse together, and this middle part between the microphones kind of dissolves away, and you end up with one unified cavity and one cervix at the bottom and a cavity in the middle. If the uterus is not developed normally, sometimes the channels will fuse and this middle part does not dissolve, so you can have what's called a didelphys uterus, which means that there are two parallel uterine cavities that are not connected in the middle. There can be a cervix at both sides. Sometimes women have to get a pap smear from two cervixes. They can still get pregnant that way. Sometimes you can have the two channels that form and one is very small and only one fully forms. And that's called a unique cornuate uterus, where half of the uterus is underdeveloped or absent. And then if you have bicornuate, that means that the channels are here, part of this has dissolved, but the top can still look like a heart shape there. And so it's usually not detected until you have an X-ray or an ultrasound or things like that. Or sometimes if women get pregnant and they have early delivery or things, then that might lead to an investigation of that. Women can get pregnant with a bicornuate or unicornuate uterus, but because the shape of the uterus is a little bit different, the pregnancy is usually likely to deliver earlier. It can be kind of cramped if the uterus is not full capacity. So preterm or early delivery is more common if you have bicornuate or unicornuate uterus. Also, babies are more likely to be breech if the uterus is not the normal open shape and the baby's kind of in one side of the heart shape of the uterus, might be kind of tucked in over there, be more likely to be breech and have C-section and things like that. And sometimes that's when it's found that, oh, the baby was breech due to C-section, and now you see there's heart-shaped uterus that's there. If it's a bicornuate, we don't do surgery for that. So you cannot go in and cut the top of the uterus, sew it and open it up, sew it back together. The top part of the uterus is the strongest muscular part of the uterus. That's where contractions for labor and things come, and so cutting across like that can increase the risk of uterine rupture and things later. So we would recommend surgery for that. But she can get pregnant. You know, if she's not ready to be pregnant, that would be something to just be aware of and to talk to her GYN or fertility specialist when she's ready for that. But there's nothing on a pap smear or just a pelvic exam usually that would have shown that.
I just have one more question.
Yes.
I'm sorry, y'all.
Questions are good.
I vaguely remember years ago hearing about a uterus transplant, about a woman that gave her uterus or sometime for her daughter, right? Is that a thing? Because you don't hear about it. Like I heard about it this one time, it made the news headline, and as quick as it made the news, it went away. So is that something that's a viable and sustainable option for people in terms for infertility?
So it is a thing, and there are women who have had a uterine transplant. It's very expensive. It's very high risk. It's about $1 million to do. When you involve the donor of the uterus and harvesting her uterus, preserving the blood flow to the uterus, preparing the woman to receive that. It's an extensive procedure. Woman, it's just like in a liver transplant or something, you have to be on anti-rejection medications and things like that. So it's been done many times in this country and outside the country, usually more in an investigational role than just something that we would recommend. And so if a woman is unable to carry, where we're recommending that she have a surrogate or gestational carrier and not go through the expense and the risk of that. But there are women who have had that, who've had a successful pregnancy and delivery with a transplant uterus. Yes, in the back.
I have a two-part question. Okay, so you said, PCOS, to kind of know you have it is like reducing testosterone, you have hair everywhere, and irregular cycles?
Yes.
Is that correct? Okay, my second question is, and then I'm sorry if I just decided to step out, but does PCOS mean that you have no chance at fertility and no pregnancy, or does it
Absolutely
mean it's
not.
harder?
It can be more difficult, especially if you don't have a period every month. I mean, you gotta ovulate the egg in order for it to be fertilized. So if you are never having cycles, then that can be a fertility factor. But I see so many women who get pregnant who have PCOS. So definitely don't want you to leave thinking that PCO means you can't be pregnant. But even if I see a woman with PCOS, we still are gonna say, if you have a partner, does he have sperm? Are your tubes open? We're not gonna be distracted and just focus on managing the PCOS and we didn't cover our bases. But if it's really open tubes and partner has sperm or she's using donor sperm, then Clomid we've used for almost 50 years. These are tablets that are not expensive, like $20 a month. If you take those, just for 5 days when your follicles are tiny at the start of the cycle, they will usually be effective in stimulating one of those follicles to grow. And you have to be careful with those kind of pills because sometimes they can stimulate many follicles to grow. And if you take the pills and you ovulate too many eggs that all fertilize, then you can have multiple pregnancies, which is high risk. But I take care of many women with PCOS who get pregnant just with the fertility pills. Letrozole is the pill that we use now more often. We use that for over 15 years though. Again, tablets for 5 days that can just nudge a follicle to develop and ovulate on time. And then some women do in vitro if they have PCOS. Again, there's a risk of overstimulation of all those follicles to just take off with a little bit of medicine. And then you can have hyperstimulation, some of the effects from that. But yes, PCOS does not mean infertility. It just means we might have to manage some factors and do some things differently. The other thing about PCOS is that there are metabolic effects to PCOS. So many women with PCOS will have weight gain, trouble losing weight, insulin resistance, risk of prediabetes now, gestational diabetes, or diabetes later. The foundation of managing PCOS is always the lifestyle. So healthy diet, less simple starches in the diet that can add to that prediabetes risk, which are white starches. So white rice, white bread, potatoes, pasta, sugar. All those are simple, they're refined. As soon as you eat them, they just spike up your sugar, your insulin, you crash and burn. So we should have less white starches and more brown carbs, which have fiber in them. They bring your blood sugar up slowly and kind of stable instead of spikes. And then just having less fried and fatty foods and things, just managing the metabolism is important for PCOS. There are many women with PCOS who are normal weight or lean. If women with PCOS have a higher BMI, just losing 5 or 10% of their body weight can also reset the ovaries and they can ovulate and sometimes get pregnant just by managing their weight. So the lifestyle is important. There's a supplement called inositol that we recommend when women have PCOS. Again, you get it from vitamin shops in different places, and that can help regulate the hormone effects of PCOS.
Thank you.
You're welcome.
Anybody have any other questions? Dr. McCarthy-Keith. Wonderful. Of course.
Okay, I have one more. Don't clap yet, don't clap yet, one more. So with the different regulatory, prescriptions and things like that, are there any, I'm sorry if this is next too, are there any like natural inhibitors that you can take to kind of combat PCOS, or is it just kind of prescription drugs that can regulate it?
The best and natural way is with your lifestyle. I am a plant-based foodie and, I just know personally the benefits of having plants in the diet, fresh fruits and vegetables, not processed food and takeout and things like that. So your diet is always the foundation. Some patients take berberine, which can also help to regulate insulin and blood sugar and things like that. So that's a supplement that can be taken. Also, berberine, B-E-R-B-E-R-I-N-E. And then inositol is another supplement. It's not by prescription that you can get from vitamin shops in different places. that can help regulate some of those PCOS effects.
Are those over the counter?
Yes,
Okay, thank you.
you're welcome. Thank you all so much for your questions. And like Dr. Costa said, I was Shady Grover Fertility here in Atlanta. If you have a question or a need, please come see us, talk to your OBGYN, start the conversation. We're happy to see you. And I'll hang around for more questions.